Today we are going to discuss about idiopathic interstitial pneumonia. Now we need to know that this is a secondary pulmonary lobule which is made up of multiple SNI. Around 10 to 12 SNI will be present, and also if you see here there is an artery which is supplying this lobule and also a bronchus which is going to the center. So there is an artery and a bronchus which is going to the center. If you see outside this, there is an interstitium present here. Now this interstitium will be present, will be containing that veins. So whenever we have to separate the interstitial lobules, we'll have to dissect along the vein. Okay, so veins are present in the interstitial, the septum, and the bronchus and the artery is present in the middle of the lobule. Now in between the two lobules, whatever the connective tissue is present is called as the interlobular septum, and this is where the interstitium of the lung is present. So everywhere we have this lot of connective tissue in between these lobules. That's where the maximum interstitium of the lung is present. So whenever there's an interstitial disease, it will affect this interlobular septum. That's what we have to keep in mind. And whenever this interlobular septa is affected, it will be appearing as some lines along the secondary pulmonary lobule. So let us understand different types of idiopathic interstitial lung diseases. So we have different terms that we use when we describe the patterns in the lung. One is the idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, cryptogenic organizing pneumonia, respiratory bronchiolitis interstitial lung disease, desquamating interstitial pneumonia, the lymphocytic interstitial pneumonia, and then we have acute interstitial pneumonia. These are the different patterns in which the patient present. Now main thing is we need to know all are present above 40 years of age. Only the respiratory bronchiolitis interstitial pneumonia and desquamating interstitial pneumonia, which are the smoking related lung diseases, these are the ones which are present in the younger age group, that is 30 to 40 years of age. And older age group, we usually see the interstitial idiopathic pulmonary fibrosis, and younger than that is the non-specific interstitial pneumonia, or the lymphocytic interstitial pneumonia, the acute interstitial pneumonia. We just have to know that the respiratory bronchiolitis and desquamating interstitial pneumonia happens in the younger age group. Now if you see the presence in the male and female, the lymphocytic interstitial pneumonia is the only one which is present in female. Rest all are more commonly seen in male, or it is equally seen in males and females. But lymphocytic interstitial pneumonia is the one which is most commonly seen with the females. Now if you see in this image, we can see that all the patient presents with the dyspnea, with cough, the dyspnea, cough, fatigue, these are the common features, the common symptoms with which patient presents. But the cryptogenic organizing pneumonia will also have fever associated with this, so it will be confused with a regular pneumonia. Cough, dyspnea and fever, we think of a consolidation. And even if you see this patient, the Hrct of this patient, again we will see consolidation. We will think of infection, and when we treat the infection, it will not resolve. After 2 to 3 months of treatment, still not resolving, think of cryptogenic organizing pneumonia along with other conditions. Now this, if you see the type of onset, we can see that the cryptogenic organizing pneumonia is having subacute onset, and acute interstitial pneumonia is having acute onset. So these are the two ones which are having acute onset. Rest all are having gradual or insidious in onset. They are not sudden in onset. So whenever we have acute interstitial pneumonia and cryptogenic organizing pneumonia, the symptoms will be sudden. Usually we expect in interstitial lung disease the symptoms is gradual, insidious in onset or slow onset, but these are the two conditions we need to know. They can have acute onset. Now acute interstitial pneumonia is nothing but ARDS without any cause. So if ARDS is imaging also looks like ARDS, but we don't have any cause, then we call it as acute interstitial pneumonia, thinking of an autoimmune cause. Now if you see the association with smoking, as I told, the RBALD and DIP are the ones which are having high association with smoking. The cryptogenic organizing pneumonia will not be seen in smokers. It is seen in non-smokers. So that's what we have to understand. The cryptogenic organizing pneumonia is seen in non-smokers. But if you have a history of smoking, you think more in terms of other conditions like RBLD, DIP, but all others are not having any smoking association. But smoking tells us if there is smoking, then there is less chance of cryptogenic organizing pneumonia. Everything will have very good response with the steroid therapy, except for the idiopathic pulmonary fibrosis, which has poor response, and acute interstitial pneumonia is already damage has done, so mortality is very high. So steroid may not help much as the mortality is already high. But idiopathic pulmonary fibrosis means that it's already undergone a fibrotic change and it's already damaged, completely damaged lung. So whenever we say idiopathic pulmonary fibrosis, you are telling that the lung is completely damaged. Okay, and that's when there is no treatment as such after this stage. Now, if you see how the prognosis, we know that it is poor in idiopathic pulmonary fibrosis, high mortality in acute interstitial pneumonia. So that's how rest of them will respond for the steroid well. So whenever we see idiopathic interstitial pneumonia, first we divide it whether it is idiopathic pulmonary fibrosis or whether it is other idiopathic interstitial lung disease. Now, idiopathic pulmonary fibrosis is a diagnosis when there is no cause. So that's why I call it idiopathic. Rest of whenever we have this pattern, whatever the pattern that we see in the lung is called as unusual interstitial pneumonia. Both means almost the same. Only thing is that if there is an unusual interstitial pneumonia pattern along with a collagen vascular disease like a scleroderma patient is having unusual interstitial pneumonia, then we think that now this unusual interstitial pneumonia is because of scleroderma, so it is not idiopathic pulmonary fibrosis. So that is the difference between idiopathic pulmonary fibrosis and unusual interstitial pneumonia. Unusual interstitial pneumonia is a Hrct diagnosis, Hrct pattern that we see, whereas idiopathic pulmonary fibrosis is a clinical diagnosis that we give to the patient depending on the cause. If there is no cause, then we call it idiopathic pulmonary fibrosis. Once we exclude this, why we have to exclude this? Because this doesn't respond with the corticosteroid therapy and it has high mortality. So that's why we need to exclude this first, and then we go to the other diagnoses that like DIP, RBALD, AIP, and NSIP and LIP. Now going on to the UIP, unusual interstitial pneumonia. So the main thing in unusual interstitial pneumonia is the pattern in which it is involving. It is involving the basal predominance and the peripheral involvement. So it is involving the periphery and the basal involvement. So periphery and the basal involvement is classical appearance of unusual interstitial pneumonia, and this is how an image looks. So this is how a normal lung looks. We can see it is appearing blacker. There are no much white lines like we saw, like we are seeing here. What we are seeing here is classically these are some cystic kind of spaces which are present adjacent to each other, sharing the wall with each other. So this is nothing but this looks like a honeycomb. So this pattern is called as honeycombing. Now why the honeycombing has happened? This honeycombing has happened because of the fibrotic change and because of the thickening of the interstitial septum and dilatation of the alveoli and the terminal bronchial dilatation. Okay, alveoli and the terminal bronchial dilatation. So this is why we see this honeycomb pattern. So because of interstitial thickening and the dilatation of the terminal bronchioles, and they are forming this layered cystic appearance in the periphery, is called as honeycombing. And also we can see the bronchus has dilated here, so it's called as bronchiectasis, which is again because of the traction, which is because of the fibrosis. What we are seeing is a traction bronchiectasis, honeycombing, and seeing the basal predominance is classical picture of unusual interstitial pneumonia. Now if you see again, we can see that there is honeycombing, there will be traction bronchiectasis, reticular opacities. These are the classical feature of unusual interstitial pneumonia. So main thing is it is basal predominance, honeycombing, reticular opacities, traction bronchiectasis. Ground glass opacities can be present but less likely. The ground glass opacity is more a feature of non-specific interstitial pneumonia that you have to keep in mind. This is how a honeycomb looks. We can see multiple cystic spaces which are sharing the wall. Now what are these cystic spaces? These are nothing but the dilated terminal bronchioles and the alveoli. And what is this? The wall is nothing but the fibrotic septations which are present. So reticular opacity is honeycombing, basal predominance is classically a feature of UIP. Here again we can see that the basal predominance, what we can see is multiple cystic layers. So this is nothing but the honeycombing, a classical feature of UIP. Again in this image we can see multiple the cystic layers which are forming layered appearance, and traction bronchiectasis, dilated bronchus. We can see that the traction bronchiectasis, this is involving the periphery, not involving the central part. Almost the central part is spared. So this is a feature of UIP. Now this image also is having multiple reticular opacities, but it is having more of ground glass opacity as well. But whenever the ground glass opacity is present, it is less focused towards a UIP. It is still progressing towards a UIP. If this is how exactly it looks, we can see that it's mainly involving the periphery. In the basal predominance, its honeycombing is present, traction bronchiectasis is present, a classical feature of UIP. Now whenever we see patterns in the chest, the first thing is we have to see whether it is a UIP pattern. When do I say whether it is UIP pattern? Subpleural basal predominance, I told, reticular opacity is present, honeycombing, and no inconsistent features. What are inconsistent features? Like how I said, ground glass opacities, they are inconsistent features. Ground glass is more towards NSIP. So there are some others which I'll tell you. Now when do I say it's possible UIP? Now whenever I say UIP pattern, that means it is UIP. Whenever I say possible UIP, there is something which is very important that is missing. Now out of these four things, which is very important? We know that it should have subpleural opacities, subpleural lesions, reticular opacities, and honeycombing. But if there is no honeycombing, it is called as possible UIP. Presence of honeycombing will tell us it is a UIP pattern, but if there is no honeycombing, then it is just a possible UIP. And if there is no honeycombing, there should be a basal predominance, there should be reticular opacities, and reticular opacities is usually seen in all the interstitial lung diseases, so it is not specific for this, but basal predominance will make it specific. And we should have no inconsistent features. So what are these inconsistent features? Involvement of upper zone is an inconsistent feature. We need to have basal predominance. Having ground glass opacity is not a feature of this, is a feature of NSIP. So peribronchovascular and profuse micronodular appearance. Okay, peribronchovascular involvement and profuse micronodular involvement is not a feature that we see in the UIP. These are the features we see in the respiratory bronchiolitis, because it is involving the bronchiolitis, bronchus is involved. So peribronchovascular is not this. And profuse micronodular appearance can be seen in NSIP, can be seen in other conditions like LIP, but it's not a feature of UIP. So anything which suggests other interstitial lung disease, it is not a feature. Or the discrete cyst, whatever the cyst that we are seeing is a dilated terminal bronchioles or the alveoli. But if such similar cysts are present, individual cysts are present, these are a feature of the presence of this individual cysts are feature of LIP. It is not a feature of UIP. Now if there is mosaic perfusion or air trapping, this all suggests towards a bronchitis kind of picture, usually seen in hypersensitivity pneumonia. So this is again not a feature of UIP. And consolidation, presence of consolidation goes towards the cryptogenic organizing pneumonia, or what we call as organizing pneumonia. So these are all the features which suggest that this is not consistent with UIP. So this is how we divide whether the pattern is UIP pattern, whether the pattern is possible UIP, or whether it is not an UIP. If any of these inconsistent features are present, we call it as this is not an UIP. Now going on to the NSIP, I told the NSIP is slightly different from that of UIP, but the mortality of UIP was very high, but NSIP is lesser, much lesser compared to that of the UIP. Now involvement here, there is no apico-basal gradient, but again this is also having peripheral distribution. Okay, peripheral distribution is seen here also. Sometimes there will be immediate subpleural sparing. Okay, sometimes a very classical feature is considered as immediate subpleural sparing is considered as classical feature of NSIP. Other than that, there is no apico-basal gradient and there is no honeycombing. That's a very important feature. We will see reticulation, we might might see ground glass opacities, we might see reticulation, traction bronchiectasis also we can see, but we will not see the honeycombing. When we see honeycombing, we should think of UIP. Now we can see here the peripherally distributed some areas of ground glass opacities. We can see throughout it is slightly opaque compared to the rest of the lung, so there is slight ground glass opacities. Now what are the other things that we see? We can see there can be ground glass opacity, along with that reticular opacities will be there. There can be small the discrete cysts, but there won't be the honeycombing appearance, but there can be small micronodular opacities. None of these were present in the UIP. There was no discrete cyst, there was no honeycombing, there was no ground glass opacity, there was no micronodular opacities in case of UIP. So this is how the NSIP presents. So if we can see here, it is mainly the ground glass opacity which predominates with some reticulations. There might be some appearance which looks like cyst, but there is no stacking of cysts like we see in the honeycombing of the UIP. Again, we can see there is peripherally distributed ground glass opacity with some reticulations, a feature of NSIP. Now this again, we can see the ground glass opacity in the peripheral area without any honeycombing. Now again, NSIP can be of two types. One is cellular type and the fibrotic type. When we see only ground glass predominance, like how we saw here, only the ground glass predominant, we call it a cellular type. But if there is more of a reticular predominance, if we can see the reticular shadows here, more of a reticular shadow, then we think of a fibrotic type of NSIP. So again, we can see more of a reticular type. It almost resembles the honeycombing, but honeycombing will have a clear cystic spaces with thick septations, which will look like a honeycomb appearance. So this looks like few cysts are having proper septations, others are not having, so they are not actually having proper overlap. Whenever I say honeycombing, it should have at least 3 layers of cysts which are sharing their walls. Okay, so that's how we call UIP. So this is again a fibrotic type of NSIP. Now whenever we see UIP and NSIP, what we have to keep in mind is that in the UIP and NSIP, the difference is the presence of honeycombing. Now if you see the mortality rate, now UIP has the highest mortality or the less survival rate, and fibrotic type of NSIP has second highest, and then comes the cellular NSIP. So cellular NSIP means it is just early stage of inflammation. We can give steroids, we can try to extend the lifespan of the patient, but whenever it goes towards the fibrotic NSIP or UIP, the mortality keep on increasing. Now again, if you just have to say in a nutshell, UIP has a epicobasal gradient, it's having heterogeneous pattern with a lot of architectural distortion. What is architectural distortion? A lot of fibrosis, a lot of traction bronchiectasis. These are all the architectural distortion. Honeycombing, the stack of cysts in the periphery because of the dilated bronchioles which are present in the subpleural location, and there is the traction bronchiectasis. These are the features that we see in the UIP, whereas no gradient, homogeneous appearance, ground glass appearance, and micronodules are the features of NSIP. So this is how we differentiate UIP from NSIP. So this is a feature of UIP. We can see how the stack of cysts are present like honeycombs in the periphery. The same image if we see here, this also looks somewhat like the honeycomb, but see how the difference is, how much. This is very vague honeycomb, but this is very obvious honeycombing. Okay, so that's why we call this, we don't call as honeycombing in NSIP. We call this mainly a ground glass opacity with some reticular opacities. That's it. Okay, so that's the difference between the NSIP and the UIP. Now if you see the cryptogenic organizing pneumonia, as I told, this patient is present with cough, the patient is present with fever, and then there will be peripherally located lesions, mainly in the basal area, and these lesions will have consolidation. So that's a feature that we see here. This is how the image will look. There will be consolidation. So again, if you see here, there is a consolidation, and outside the consolidation we can see that there is some areas of ground glass opacity. So there is this areas of consolidation surrounded by a halo of ground glass opacities. So this is how cryptogenic organizing pneumonia appears. So this usually contains a ground glass opacities in the center with a surrounding consolidation, what we classically call as the atoll sign. Okay, now this is again a picture of cryptogenic organizing pneumonia. We can see here the ground glass opacity surrounding the consolidation. It's nothing but the atoll sign. We call it as atoll sign or the reverse halo sign. Normally in a condition where there is consolidation with surrounding hemorrhage, like in case of invasive aspergillosis or a tumor which has bled, we can see outside ground glass opacity with central consolidation. That is called as a halo sign. Now reverse halo sign, in which there is central ground glass opacities with peripheral consolidation, we call it as a reverse halo sign or atoll sign. Now this is what we see here. Now whenever we give steroids to this patient, see how rapidly the lesions disappear. This is what we see in the cryptogenic organizing pneumonia. But the same patient, if you would have put this patient on the antibiotic for 2 months, 3 months, again the patient will not resolve. That's how we diagnose cryptogenic organizing pneumonia most of the time. It will be a treatment failure for a pneumonia. That's when we think of cryptogenic organizing pneumonia. But if in case we think earlier, we could have treated the patient earlier with a corticosteroid and it will resolve rapidly, and that's how we treat the cryptogenic organizing pneumonia, and that's how it looks. Now going on to the respiratory bronchiolitis, interstitial lung disease and DIP, these two are the conditions which are seen along with in the smokers. Now RBILD is usually seen in smokers, mainly involving the upper zone predominance. There will be ground glass opacities in the upper zone. Also there will be we can see some punctate nodular lesions seen in the upper lobe. So these are nothing but the centrilobular nodules. This is how the nodules which will be present in the lung, along with that ground glass opacity in the upper lobe predominance, is a classical feature of RBLD, because smokers, the air can go mainly in the upper lung. So because of this, we can see this changes in the upper lung predominantly, and we can see like this, there are small ground glass nodules which are present mainly in the upper lobe predominance. Also there can be some cystic centrilobular emphysema kind of changes because of the cystic changes which is happening because of damage that is caused by the smoke. Now again, diffuse interstitial pneumonia, it's other spectrum of the RBLD, the severe spectrum of RBLD. In the RBLD we saw there was ground glass centrilobular nodules, whereas in the DIP the RBLD was mainly involving upper lobe, whereas DIP is having involvement throughout. This appears almost like that of NSIP. It's involving peripherally throughout the lung. The ground glass opacities with some reticulations is what exactly we see here. And if you see here again, there will be reticulations, ground glass opacities, few cystic spaces. So looks almost like NSIP. But if you see the age group that we saw was DIP and RBLD was 30 to 40 years of age, whereas NSIP was 40 to 50 years of age. So the age group also will add on, and the history of smoking also will add on to the diagnosis of the DIP, which is having this peripheral involvement. And also we can see that there is some ground glass opacities, reticular opacities, and some cystic changes. Now this is how the picture looks. We can see the ground glass opacities in this patient and few cystic spaces we can see. It's almost like that of NSIP. But what one more specific thing that we can see in the NSIP is, in NSIP there will be immediate subpleural sparing is one of the classical feature which will not be seen in DIP. Keep in mind the immediate subpleural sparing will be seen in NSIP, not seen in DIP. In DIP what we see is this peripheral ground glass opacities. We can see small cystic spaces also present inside this ground glass opacity. This is how a classical DIP presents. There is no apicobasal gradient, there is no upper zone predominance like that of RBLD, but there is peripheral involvement, ground glass opacities. We think of DIP, desquamating interstitial pneumonia. Okay, DIP means desquamating interstitial pneumonia. I might have wrongly told diffuse interstitial pneumonia. Okay. Now this is a feature, this is a case of lymphocytic interstitial pneumonia. Again, it will have predominantly involvement of diffuse lung. Okay, there is no involvement of upper zone or lower zone. It's a diffuse lung involvement, and there will be ground glass opacities. But there will be diffuse ground glass involvement of the entire lung. But what is specific here is the presence of this perivascular cyst, the countable number of perivascular cysts. Okay, there are countable number of cysts. We can just count, it will be 10 to 12 cysts will be present in these patients. So it can be counted, and it is mainly seen adjacent to a vessel. So we can see a vessel going here which is very whiter, and we can see a cyst next to it. So this is how a LIP present. Now it is nothing but a diffuse ground glass opacity with countable number of cysts. Now this is again a feature presents the feature of LIP, in which there is diffuse ground glass opacities with few cysts, but the cysts are not clearly seen. We can see some cysts, but they are not clearly seen because there is diffuse ground glass opacity. Also we can see a lot of reticular opacity. This is all interstitial lung disease can have reticular opacity. That's why even this can have reticular opacities. I'm not specifying that because that are not the specific features. What is the specific feature here? Diffuse ground glass opacity and some perivascular cystic spaces. Now, if I give steroid to this patient, see how the patient improves suddenly, and then we can see the perivascular cystic spaces. You can see a vascular dot here, the adjacent to that is a cyst. Like this, we can see the cystic spaces in the LIP. Now whenever we see the cysts in the lung, diffuse cystic lung disease, there are different types. One is a LAM, lymphangiomyomatosis, LIP, lymphocytic interstitial pneumonia, LCH, Langerhans cell histiocytosis. Out of these things, the LCH is associated with smokers, and if you see, LAM is associated with tuberous sclerosis and seen in female patients. Chylous effusion will be present in this patient, and in the Langerhans cell histiocytosis usually seen in smokers. There will be nodules which are present, and again this is a smoker. There will be involvement of upper zone predominant, and these nodules will undergo cavitation, and that's how these nodules will have thick margins sometimes and irregular cysts, thick margins. Upper lobe predominance is how a Langerhans cell histiocytosis will be present, whereas LIP is having perivascular cysts with diffuse involvement and countable number of cysts. Now this is a case of Langerhans cell histiocytosis. We can see some nodules here. We can see some cysts of different wall thickness. Some are thin walled, some are thick walled. This is because it's a nodule which is undergoing cavitation. So we can see this image. We can see this, how this is appearing like the nodule has undergone cavitation. That's a picture that we see in a Langerhans cell histiocytosis. Whereas if we see LAM, we can see multiple cysts of a smooth walled cyst of variable size, very highly prone for pneumothorax, very high chance of chylous ascites will be present in this patient. Chylous effusion will be present in this patient, and there will be reticular opacities like any other diseases associated with tuberous sclerosis seen in female patient. And these patients will have renal angiomyolipoma because it's associated with tuberous sclerosis. Now that's the DDs for the cystic lung disease, because we saw the cysts in the LIP. Now if you see acute interstitial pneumonia, this is nothing but same as ARDS but with an idiopathic cause. ARDS with an idiopathic cause is nothing but acute interstitial pneumonia. Mainly involves the central lung, unlike other conditions. Here involvement of the central lung, not the peripheral lung, and it's mainly basal predominance more common than the apical. The dependent area is more mainly involved. Now here we see how we can see the ground glass opacities like we see here. We can see the consolidation like this. This is the early stage in which call it as the cellular stage again. Okay, we'll be having these ground glass opacities, consolidation in the central distribution. Mainly the basal predominance will be there, and there can be traction bronchiectasis. Now this is how the picture looks. The dependent area is showing consolidation, the ground glass opacities in the central distribution. See how nicely the periphery is spared. See how the periphery was involved in case of UIP, but here see how nicely it is spared. Now this patient will progress to a fibrotic stage. Whenever they progress to fibrotic stage, it will usually involve the non-dependent area with this fibrotic change, where we can see the traction bronchiectasis, reticular opacity. So this is how we see acute interstitial pneumonia, where we can see that there is traction the fibrotic stage, the cellular stage. The cellular stage will have consolidation, ground glass opacity, dependent area, whereas a fibrotic stage mainly involves the non-dependent area with reticular opacities and the traction bronchiectasis.